Support for healthy eating improves health outcomes among people with HIV. A clinical trial has found that medically tailored meals and groceries, combined with nutritional education, can reduce hospitalizations and improve mental and physical health in people with HIV. However, the intervention did not yield any improvement in terms of unsuppressed viral load, according to the report in the Journal of Infectious Diseases. The Changing Health Through Food Support for HIV Study, CHEFS-HIV, was conducted by Dr. Kartika Palar from the University of California, San Francisco, UCSF, in partnership with Project Open Hand, a non-for-profit nutrition agency based in the San Francisco Bay Area. The trial compared an intensive medically tailored intervention matching food support with health and medical needs, a food as medicine approach, to standard of care food services provided by Project Open Hand. The study investigated whether or not this intervention could help to reduce viral non-suppression among participants, as a primary outcome. It also explored the impact of food as medicine on the following secondary outcomes: food security, symptoms of depression, adherence to antiretroviral therapy, hospitalizations, and how many times participants had had condomless sex in the last 3 months. Several reasons brought Palar and colleagues to conduct the CHEFS-HIV study. Among people with HIV, food insecurity in high-income countries is associated with poor quality diets, mental health challenges, sexual risk behavior, less adherence to antiretroviral therapy, lower CD4 cell counts, higher viral load, and increased mortality. Furthermore, both food insecurity and HIV disproportionately affect low-income and ethnic minorities. The investigators had previously evaluated the food as medicine approach with a pilot study of 52 people with HIV and/or diabetes, resulting in improvements in food security, symptoms of depression, and antiretroviral adherence. However, as this study was small, had no control arm, and did not assess viral load, its results warranted a more thorough investigation. The CHEFS-HIV study recruited 191 participants in 2016 to 2017. HIV-positive clients of Project Open Hand could participate if they were at least 18 years old, spoke English or Spanish, had the ability to store and reheat perishable food, and had a household income lower than 200% of the U.S. federal poverty level, reflecting food insecurity. For a single person at the time of the study, income would have been below $23,760. 93 participants were assigned to the intervention arm, which provided food as medicine for 6 months, medically tailored meals and groceries, equivalent to 3 meals a day, designed to meet all daily energy requirements, based on an average of 1965 to 2359 calories/day. Importantly, the food plan varied each week, was low in refined sugars and saturated fats, and contained fresh fruit and vegetables, lean proteins, healthy fats, and whole grains. A grocery bag was provided as additional to meals, to ensure that all food groups and daily nutrients were included. The intervention was informed by guidelines from the American Diabetes Association and the American Heart Association, nutritional education, 1 individual nutritional counseling session at the start of the study, baseline, and another towards the end, 1 assessment call at 3 months, and 3 2-hour small group nutrition classes covering HIV. Nutrition, portion size, food labels, goal setting, and cooking demonstrations. The other 98 participants were assigned to the control arm, consisting of receiving groceries or prepared meals sufficient for 1 or 2 meals a day, and meeting briefly with Project Open Hand dietitians every 6 months, but with no nutritional education. Outcomes were measured at baseline and at 6-month follow-up through blood tests and a standard quality of life self-reporting questionnaire, the SF-36, whose highest score is 90. Results: most participants were men aged 50 years and over. Most were from ethnic minority backgrounds, with an education level superior to high school. Many, 30%, had used illicit drugs in the past 30 days and had a self-reported mental health diagnosis, 60%. Median time since HIV diagnosis was 22 years. 40% had diabetes, hypertension, or cardiovascular disease. At baseline, viral load was unsuppressed in 36% and the mean quality of life score was 52.4. Almost 2/3 of participants, 63%, were food insecure. 46% had symptoms of depression, 22% missed more than 1 in 10 antiretroviral doses, 8% had had an overnight hospitalization in the past 3 months, and 61% had had condomless sex in the same period. After 6 months, 168 participants, 88%, remained in the study, which is a high retention rate in this setting. Retention was similar in both arms, while the rates of unsuppressed viral load decreased in each arm, probably due to intensified local outreach and services at the time. No significant differences between the two arms were found for this parameter at 6 months. Neither were there differences in terms of quality of life. However, the risk of becoming severely food insecure among the food is medicine participants was reduced by 77% over 6 months, odds ratio 0.23, 95% confidence interval, 0.87 to 6.17, when compared to the control arm participants. Also, the risk of severe symptoms of depression was reduced by 68%, or 0.32, 95% CI, 0.125 to 0.834. A greater decrease in fatty food consumption was noted, but there was no difference between arms regarding fruit and vegetable consumption. In the food as medicine arm, rates of poor antiretroviral therapy adherence were lower, or 0.18, 95% CI, 0.0389-0.821, as were rates of condomless sex, or 0.05, 95% CI, 0.00385-0.528. Finally, the proportion of participants hospitalized in the past 3 months decreased from 11% to 5% among food as medicine recipients, while increasing from 6% to 11% in the control arm, which translates to a significant 89% lower risk of hospitalizations, or 0.11, 95% CI, 0.0134-0.960. In the intervention arm. Conclusion: Palar and colleagues argue that food as medicine programs can improve physical and mental health outcomes in people living with HIV. They also highlight the positive impact of their program on sexual behavior, which confirms the well-documented link between food insecurity and risky sexual behavior, for example, when transactional sex occurs. Explaining the program's impact on hospitalizations, they point out that social factors linked to food insecurity such as homelessness and illicit drug use are major contributors to emergency department use, hospitalization, and death in San Francisco. In an accompanying Journal of Infectious Diseases commentary, Dr. Seth Berkowitz from Johns Hopkins University also stresses the importance of the decline in hospital admissions, but doesn't view it, as is often the case, from the sole perspective of economics. A reduction in hospitalizations can be seen as an indicator of improved health. He says, Berkowitz praises the CHEFS-HIV study, but reminds us that it should be considered in a broader social context. Food as medicine efforts are attempts to mitigate the consequences of adverse social circumstances, but do not confront the social injustice that creates them in the first place. Doing so would require more focus on reforming the social institutions which distribute power and resources in the U.S.